Hi everyone, welcome to our Learning Collaborative webinar on cognition and memory assessment tools. We're glad everyone's here today. We will start with just a few announcements, and I will turn it over to Erin Long for the first.
Hi. I just wanted to thank everyone for taking time out of your day to attend the webinar. I hope that it meets your expectations. We are excited to be putting it on, and I really don't have any announcements, but I believe Josh has an announcement that he would like to make.
Hi, this is Josh Wiener. Along with Liz Gould, I'm the co-director of the ADSSP National Resource Center. And I'd like to announce a reorganization of sorts with the Resource Center. Starting on October 6th, Liz Gould, Sari Schumann, and Patty Ewan will be transitioning from the Alzheimer's Association to RTI International. So at that time, they will become employees of RTI rather than of the Alzheimer's Association. Their functions and activities will remain the same. So I'm very pleased with this change and think that it will help solidify what has already been a very seamless relationship among the members of the ADSSP Resource Center team. And I'd like to welcome them to RTI, and starting on the 6th or thereabouts, or before, we'll be sending around new information about how to contact them, including their new email and telephone numbers. But we're very pleased and excited, and again, want to welcome them to RTI. Thanks, Sari.
Thanks, Josh. So at this time, I'm going to turn things over to Lisa Lines, who is at RTI and is going to be presenting for us today on the screening, identification, referral, and care planning toolkit that we put out last year for the Learning Collaborative. And Lisa, why don't you go ahead?
Oh, thank you, Sari. So as you all may know, in the community, fewer than half of people with AD are diagnosed, and undiagnosed AD prevents patients from beginning treatment and planning to cope with future declines. Underdiagnosis also prevents caregivers and family members from taking advantage of support services. So, this is a really important issue, and that's what we'll be talking about today. In my part of today's webinar, we're going to be talking about three things. First, I'll describe 7 screening instruments for possible AD and other dementias that can be administered by people without clinical training. And then I'll give you a quick evaluation of these tools. And then I'll go over 4 needs assessment and referral tools that are available for potential use. And finally, we'll discuss tools used for care planning, screening, and referral by current system integration grantees of the ADSSP program in 4 states: Georgia, Minnesota, New York, and Ohio. So this is a list of the 7 instruments I'll be summarizing, and they're commonly referred to by their acronyms because we all love acronyms. So we have the BSCI, the CDT, the OABC, the PHC-COG, the SDS, the TICS-M, and the TYM. And you may notice that the MMSE is not on this list. And the reason for that is because our criteria for selection for these instruments was pretty specific. We required that instruments be intended to screen for, but not diagnose, dementia, cognitive impairment, or AD. And we excluded instruments that were intended to screen for delirium. The second criterion was that the screening instrument was clearly and explicitly intended to be administered by a lay interviewer in person or by phone, either to the client or to a knowledgeable informant, such as a caregiver or a spouse. So, and then that means that the instrument was not intended to be solely self-administered and was not intended to be administered solely by physicians, nurses, social workers, or other clinicians. And then the final criterion was that the supporting journal article about the screening instrument had to have been published in English with an abstract available, preferably published in the last 10 years, although we did identify some key older articles as well via searches of bibliographies. So, so that's why you don't see the MMSE on this list, because we did not actually identify any journal articles testing the MMSE for administration by non-clinicians, although it is one of the most commonly used instruments. So let's move ahead to the first instrument on the list. That's the brief screen for cognitive impairment. So this is a very brief screen. It only has 3 items, and it was designed to be incorporated into the health risk assessments that are often conducted when people first sign up for Medicare managed care. They're given a telephone screener. It's got just the 3 items: delayed recall of 3 words, and how often the person needs help with planning trips for errands, and how often the person needs help remembering to take medications. There's also a 2-question version for Medicare enrollees who don't take any medications, and that actually performs similarly. So it's a very brief screen, and was designed for these health risk assessments. The next instrument is the clock drawing test. It's a paper and pencil test, so it has to be administered either in person or by mail. And it's a pretty simple test. The person administering the test just asks the client to draw a large clock face and put all the numbers in, and then draw the clock hands to indicate 10 past 11. So quick, and on the right there you see some examples of some different versions of the clock that have been drawn by people with different levels of impairment. The scoring is also pretty straightforward. Okay, the next one is the older adult behavior checklist. This was designed to be administered to a knowledgeable informant, not to the client. It has 113 items describing problems and 20 items describing strengths from the perspective of the knowledgeable informant. And it has a recall period or a look-back period of about 2 months, and it can be done either on face-to-face or online, or face-to-face or paper or online, and it takes about 15 minutes. And the scales are listed there. Okay, so next we have the PHC COG, which was also designed to be administered by laypersons and used for population-based screening. It was actually developed in Korea and intended to be given to people when they visited a clinic for flu vaccination. So there's actually an item on there about that. So it's not necessarily applicable to all situations. It includes items derived from the MMSE and the Bartel Index and the IADL, and then this Korean screening questionnaire. It has 5 items that are administered to the clients and 15 items for the informant, the knowledgeable informant. It takes about 1 minute. Next, we have the Symptoms of Dementia Screener instrument. It has 11 items, yes or no questions, that are listed there on the right. It's designed to be given to a knowledgeable informant and designed to be applicable to general public without any special expertise or training to administer. And next we have the Telephone Interview of Cognitive Status Modified, TICS-M. This is a computer-assisted telephone interview designed to be administered by lay interviewers, and it has several cognitive domains. The items are listed there on the right, and the scoring. It's modeled after the MMSE, but it was modified to remove items not suited to telephone administration and then tested to see how well it performed administered by lay interviewers. The delayed verbal recall measure increases the sensitivity for early dementia and mild cognitive impairment. And then finally, we have the Test Your Memory, TYM. It was designed to be given by laypersons and to test a range of cognitive functioning. It takes about 5 minutes, is a pencil and paper exam. The items are listed there on the right. And to sum up here, we have some evaluation criteria. So ideally, a screening instrument would be brief, would be very easy to score, very accurate, and for our purposes, we define that as the um, negative predictive value of greater than 85% or specificity greater than 85%. And just to define those for you, the specificity is the number of true negatives divided by the sum of the true negatives and false positives. It's also known as the true negative rate. In other words, it's how likely is the test to detect the lack of a characteristic in someone who does not have that characteristic. And then negative predictive value is the number of true negatives divided by the sum of the true and false negatives. In other words, the proportion of persons with a negative result who do not have the characteristic. So an instrument with 99% negative predictive value is 99% accurate in determining whether a person does not have dementia. So that's what we want for a screener. We want to screen out people who don't have the condition. And then the other criteria were that it be administered by laypersons by phone or face-to-face and freely available. We've evaluated each of the instruments according to those criteria, and the best instruments by these metrics were the CDT and the TYM for face-to-face, and then the BSCI and SDS for phone. And I apologize, there was an error when we created these slides. The BSCI was actually very accurate, but we don't have the check mark under the very accurate column. So it is actually very accurate, meets that criterion of NPV or specificity greater than 85%. So we have 4 instruments that really meet our ideal characteristics. Okay, so the next section, we're going to be talking about needs assessment and referral tools that are available. And we have the criteria for selection here on the next slide. We required that these tools be designed to assess a variety of needs for people with dementia or cognitive impairment or their family caregivers. These tools can be completed by counselors, care coordinators, family caregivers, and involve follow-up for identified areas of need by a trained counselor or caregiver specialist over the phone, or in person, or on the internet, or offer a resource link to such a person. And we required that they be accessible on the internet. So the first tool is the Duke University Information and Assistance Toolkit. And this was it was originally developed by the North Carolina Project CARE. It's an 88-page toolkit, so it's actually a very substantial body of work. It was developed for information and assistance specialists and care managers, and provides a lot of information to help those folks enhance their communication skills with family caregivers. And it also has a one-page problems and solutions sheet to sort of help people understand where they might look for help with different issues that they're facing, whether they need respite care or a social worker or a support group. It provides a nice list of common situations and places people could go for support with those problems. The Alzheimer's Association Alzheimer's Navigator is a free, interactive, web-based assessment and referral system that generates customized information sources for family caregivers and their people with dementia. It has a survey that starts off a 5-minute survey with trigger questions, and those answers to those questions will lead to more focused survey items in specific areas, such as the person's knowledge of AD and various future planning pieces. And then there's an action plan that comes out of this that has links to local resources and information about the disease and action steps. Next, we have the Benjamin Rose Institute Care Consultation Tool. It's a telephone and web-based information and support service for older adults who have at least one condition or disability and a friend or family caregiver. So there's an initial brief telephone interview with the same kinds of trigger questions. And the output of this is to provide care consultation with professional counselors. And there's also a lot of intervention materials and supporting software, training, ongoing support. All of that is available for a fee. And Next, we have next and last, we have the Tailored Caregiver Assessment and Referral Navigator, or TCARE. It's another product that is available. Um, it's a licensed product. It's a 6-step assessment and referral process that helps care providers to develop the care plans that they need based on their needs. And there's a 32-item assessment that helps caregivers develop their goals and strategies, and to locate available and appropriate resources. So we evaluated these tools on several criteria, whether it was available online, the cost, and who was supposed to be administering these tools, whether there was training required, and efficacy. We have a situation here with these tools where the two that are free and available online, there's no actual, they're not necessarily evidence-based. So we don't have any studies we can point to that say, oh, these tools have these benefits that have been assessed. The other two tools that do have a cost associated with them have had some research done on them, and there is some evidence about their efficacy in terms of improving care and fewer visits to EDs and hospitals and that kind of thing. So it's kind of a trade-off here. There was no tool that we identified that was free and also had the evidence base. In the third section here, we're going to be talking about the tools that are currently in use by ADSSP grantees in 4 states. I'm going to start with Georgia. In Georgia, they're using the Determination of Need Revised, the DONR. It was actually originally developed in Illinois, and it's used now in Georgia and probably other places as well. It assesses impairments and needs for care in 15 domains, and the domains are listed there on the right. And for each domain, there's a little simple score where you can have some comments as well from the assessor. This is typically done over the telephone. And then also in Georgia, they have the Gateway Needs Assessment Flowchart that's used to help people who reach the gateway with no wrong door and the single entry port for all aging services, statewide gateway. So they receive, calls, faxes, emails from clients, and the gateway staff enter their information into the database. And depending on whether the person needs just information or referral or options counseling in terms of long-term services and supports or intake and screening, that determines the flow of people through this chart. The intake and screening includes the DONR, Determination of Need Revised, and TCARE assessment. Next, let's turn to Minnesota. In Minnesota, they have the Senior Linkage Line, and it's something that is used to connect callers to services and information in their community. And they also offer face-to-face help in homes and communities. So to talk a little bit more about what goes on that Senior Linkage Line, they have this flowchart that is used to, as a, in part of the statewide effort to help people get through the whole system of finding resources and getting care. So when someone contacts the Minnesota Linkage Line, they're assessed with either the mini-cog, or generally the mini-cog is the first instrument that's administered, and then depending on whether the person is in the normal range or not, they're assessed further. Then they're either referred or referred for further workup or to a care coordinator. And there's a flow of people through this chart that is designed to help make a very standardized process. Also in Minnesota, they have 4 tools I'm just going to talk about briefly. The Family Questionnaire is one tool that they're using. It's a 5-question tool that was developed by the Alzheimer's Association and the National Chronic Care Consortium. It's designed to help people over age 65, help identify those folks with memory problems who don't have a diagnosis of dementia and have come to a clinic with a family member or friend. And so it's very simple scoring. There's 5 questions. Each is answered on a 0 to 2 scale, so not at all, sometimes, or frequently. And then the scores are summed, and then any scores greater than 3 are intended to prompt further evaluation. So that's how that one works. The mini-cog is another instrument that is used in Minnesota. It incorporates both a clock drawing test and a 3-word delayed recall test. So the administrator will give the person 3 words to remember, like banana, sunrise, chair, and then a few minutes later they'll ask them to repeat those words back. The MoCA is another instrument that's used, the Montreal Cognitive Assessment. And it's a screening instrument for mild cognitive impairment. It takes about 10 minutes to administer, must be done face-to-face, and it has 11 tasks, including a clock drawing test and a delayed word recall. And then the last one that's used is the SLUMS, the St. Louis University Mental Status Examination. It has 11 questions, including a clock drawing test and items about orientation to time and place.
All guests have been muted.
Okay. Okay, so that's what's going on in Minnesota. Let's turn our attention to New York. In New York, they have a system, the New York Connects, and that they're using the AD8. The AD8 is another screening instrument that has 8 items, as the name suggests. The items are listed there on the right. Well, I'm sorry, I spoke too soon. They're not using it necessarily, but last I heard they were just considering it. So maybe someone else has more up-to-date information, but the AD8 does have specificity of around 80% and negative predictive value of about 70%, so not the most specific instrument. However, that is what's being considered. But just to, one more thing about the New York Connects, it's the single point of entry agency, statewide, provides free, objective, comprehensive information. And in Ohio, Ohio has the Dementia-Capable Ohio Screening and Assessment Process, the Universal Screening and Assessment Process, and they're using several recommendations for tools. They suggest that anyone with any of the 10 signs from the Alzheimer's Association should get further screening. Anyone who's had concerns expressed about their situation by their family, or if they have their own concerns. People who work on these phone lines are coached to listen for repetition, a confabulation, confusion, disorientation, difficulty focusing, and then any changes in personality, behavior, lucidity, memory. And the tools that are recommended are listed there on the right-hand side. Most of these we've already talked about. There are a couple that I haven't mentioned already, and those are the Memory Impairment Screen, the MIS, which has 4 tasks, takes about 4 minutes, and is administered to the client. And then the GPAC, the General Practitioner Assessment of Cognition, that's an instrument that was designed to be given in a primary care setting. Takes about 4 minutes with the client, and then another 2-minute interview with the caregiver. Includes a clock drawing test, orientation to time and place, pencil. It must be done with either paper and pencil or online. So those are the tools that we've identified, and for more information, there's a paper that we've written up that has a lot more information about each of these tools, and it's available online. That was done last year. And you can also reach out to either myself or Josh Wiener for more information.
Thanks so much, Lisa. That was very informative. And all of the Learning Collaborative members also received the screening toolkit via email this morning. So everyone should have it on hand in their email. If you don't, for some reason, you can contact me, and I will get it to you, or Lisa. So we're going to move on. And memory assessment items. Feel free to enter questions as I'm speaking, and we'll address them at the end of our call. I'm going to stop around 11:45 my time, about 15 minutes before the hour, to address questions. So as you all found in your email this morning and we sent previously, we recently put out a policy brief where we reviewed cognition and memory items in 3 federal assessment instruments: the minimum data set, the outcome and assessment information set, and the continuity assessment record and evaluation tool for home health and institutional admission. As you all know, one of the features of dementia-capable long-term care services and support systems is their ability to identify Alzheimer's disease and other cognitive impairments. So in reviewing these tools, we looked for the items that were most related to cognition and memory to see what we could provide you as useful tools for parsing out who might have a memory issue when you are doing your assessment. So in the attachments to the policy brief that I sent this morning, you will find the actual items related to cognition and memory from the MDS, OASIS, and CARE tool. So you can refer to the back of that document if you want to see the actual items. The first tool that we're going to talk about is the minimum data set, or the first set of cognition and memory questions that's included. The minimum data set has a set of screening, clinical, and functional status items that assess all residents of nursing homes certified to participate in Medicare or Medicaid. The items in the MDS are used to standardize communication about resident problems and conditions within nursing homes, between nursing homes, and between nursing homes and any outside agencies that might be assisting nursing home residents either while they are in the nursing home or as they transfer out. Section C of the MDS is where we found the cognition and memory questions. There's 2 sections: the brief interview for mental status, or the BIMS, and then a staff assessment of mental status can be used. The results of the questions determine a resident's attention, orientation, and their ability to register and recall new information. So in the MDS 3.0 is when the BIMS was introduced. It looks at concentration, recall, and orientation through the repetition of 3 words, temporal orientation, and recall of those 3 words. The BIMS is actually a performance-based assessment, and it was shown to have excellent reliability, and in testing it also was preferred by the majority of staff who used the instrument compared to the tool that was priorly used in the MDS 2.0. And as I mentioned, if you would flip back to the back of the policy brief, you will see the BIMS questions in attachment A on page 4. The staff assessment of mental status is also in the MDS. This is used if a resident is rarely or never understood verbally or in writing. So this is examining short and long-term memory, memory and recall ability, and cognitive skills for daily decision making. The items that are used for that staff assessment in the MDS are in attachment B of the policy brief. That gives you all the items and how and what the scoring options are. So as we move along, we are now at the OASIS tool. This is a standard instrument that's used for Medicare home health patients. There's not a specific tool that's included in OASIS. There are just items related to neuroemotional and behavioral status. In addition, the OASIS allows those who administer the tool to indicate patient diagnoses, and diagnoses are listed with ICD-9 CM codes. In certain cases, whoever's administering the OASIS can choose from a list of conditions that existed in the person prior to an inpatient stay, or when they've had a change in their medical or treatment regimen. And on the list that they can that the people administering the test can choose from, memory loss is included in this list. So the neuroemotional behavioral status items you can find in attachment C, and it explains in that attachment what these items are based on, and they're based on cognitive functioning, confusion, cognitive, behavioral, and psychiatric symptoms, and frequency of disruptive behavior symptoms. The cognitive functioning looks at the current level of cognitive functioning, including alertness, orientation, comprehension, concentration. The item is supposed to be completed at the start of a patient's care, if they leave and come back for care, so the resumption of care, and then discharge from the agency. There are 5 scoring options for the cognitive functioning item, and that is, they're all listed out in that attachment C. The confusion item is basically what it says. They're looking for time of day and situations when confusion arises for the person that is getting services. Then there's cognitive, behavioral, and psychiatric symptoms, looking at memory deficit, impaired decision-making, verbal disruption, physical aggression, disruptive or inappropriate behavior, and delusional, hallucinatory, or paranoid behavior. And finally, the frequency of disruptive behavior symptoms. This is looking at behaviors that are disruptive or dangerous to the patient or their caregivers. And all of these items, like I mentioned for the first, are supposed to be taken care, completed at the start of a patient's care, the resumption of care, and discharge. So the third tool that we examined is the CARE tool, the Continuity Assessment Record and Evaluation Tool for Home Health and Institutional Admission. This was developed as part of the National Post-Acute Care Payment Reform Demonstration. And the CARE item set is used to standardize the assessment of medical, functional, cognitive, and social support status across acute and post-acute settings. Interestingly, the CARE uses the BIMS as well. We've talked about that when we were addressing the MDS tool. The minor change that was made for the BIMS in the CARE tool was really just replacing the word resident with the word patient, since the CARE tool is not used for inpatient. They're not residents of nursing homes like they are with the MDS. Also similar to the MDS, if a patient can't be interviewed using the BIMS, then there's an observational assessment that can be administered. And the items for this observational assessment are related to a person's observed memory or recall ability, such as whether the person who's administering the assessment has seen that the client knows the season, location of his or her room, the staff names and faces, or that they know what setting they're in. So in reviewing these 3 tools, we learned in these tools and the tools that Lisa talked about, there's lots of valid and reliable tools out there to look at a person's cognition and memory. And for all of you that are working in your states, using an already validated and reliable tool could be a time and or money saver. That is a review of those tools. You do see my new contact information here, but please know this is 99%, and you can reach me at my current email address, which I will remind you of in the Q&A section, until October 3rd. So with that, we'd like to open it up for questions. I had 2 come in as we were talking, and they're actually for the states of Minnesota and Ohio. So in order to answer these, I know we have a few folks from Minnesota on the line. Here's the question that came in from Minnesota. So Donna or Mark, if you have an answer to that and you want to type it in, that would be great. The question came from Jennifer Mead in Oregon. And then I did see, Treasurer Miller, that you are on the webinar. I don't know if you would have the answer to this question yet. I know that you are new to our work with the Learning Collaborative and with Ohio. But if you do, you could put your answer right here in the chat feature. And if not, you can feel free to pass this question on to Deanna Clifford, who might have the answer. So if anyone has questions, you can enter them right there. It looks like we have some responses coming in, so a response to the Ohio question. So we'll just pause for a minute to get that. But if you have questions of your own, please feel free to include them.
So this is Josh Wiener. I just was going to make a comment, which is that in terms of the reason we spent so much time trying to identify these kinds of instruments is that it's hard to provide dementia-capable services if you don't know who you're supposed to be providing them to. And in more population-based um, settings like ADRCs, where people are coming to you with a wide variety of needs, there's a need to have some way to sort people into people with dementia and people with probable dementia or possible dementia and people who don't have dementia. And so that once you make that sorting, you can that can trigger some of the kinds of care planning and referrals that Lisa was talking about in the second part of her presentation. So this is really a kind of foundational cornerstone to setting up a dementia-capable system.
Thanks, Josh. Treasurer Miller from Ohio will forward the question that Jennifer Mead had to Deanna Clifford. And I will, depending on what the answer is, I'll either send it to all of you or to Jennifer, depending on if it's state specific or not, or if it has relevance. And then Donna, I think I just saw you enter the room again. There you are. So Jennifer, if you're seeing the response from Donna, she said that in Minnesota, the senior linkage line staff connect to a memory care consultant who does the mini cog or a clinic. Maybe, or refers them to a clinic. So Jennifer, if you have further questions about those, you can include them here. And Donna says yes, refers them to a clinic. Okay, we'll just wait another minute or so to see if anyone else has questions, and if there aren't any, we'll adjourn a little early for today. And also, just so everyone knows, this session is being recorded, so we'll be able to have the recording available for any of your colleagues that were unable to attend today. And then we have a question come in from Deborah Cherry in California, wanting to know if any state has a simple tool to identify a caregiver. This relates to the work that they're doing in California for their SI grant, when they're working with the health plans, trying to identify the health plans. They're trying to get them to identify the caregivers. So if anyone does have a simple tool, you can indicate it here in the chat pod, or you can send it to myself or Deborah directly. Lisa, do you know of any?
I I'm not sure what is meant by this. I'm a little I'm a little confused by the question.
Okay. Deborah, if you have any other specifics of what you're looking for, feel free to include that.
So this is Josh Wiener again. Uh, um, so obviously all of the states, when they do an initial assessment of individuals who are applying for various home and community-based services, they all ask about whether someone has a caregiver or not. Um, I'm not sure any of them have been tested for validity or reliability, since it's primarily a matter of fact rather than a measurement of some underlying concept. If Deborah is looking for more than just a binary does not have a caregiver, um, there are a number of, I mean, again, every state has some kind of assessment. In an environmental scan that we're doing for CMS under another project, we do review state instruments looking at assessing the existence of caregivers, but that probably will not be available until probably the end of the year, maybe the beginning of next year.
I know in a prior study that I worked on, we had to define who was the family caregiver, or sort of as an inclusion criteria for being included in the study we were doing, and we defined it as someone who spent at least an hour a day with the person. So I don't know of any published tools or anything like that, but I know that. Yeah, I'm not aware of any validated tools, but I know that this is a question that people have asked. How do you define who is the primary caregiver, who's the family caregiver? And that was the definition that we used, but that's something that I'm not aware of any research on that particular area.
All right, thanks to both of you, Lisa and Josh. In the OMB guidance for our data requirements for ADSSP, there's a frequently asked questions document. There are some definitions in there for who we define as caregiver for the projects. So that also might have the definition might help drum up some questions that would be useful, Deborah, and others from California or anyone else that might need something like that. But as you heard, there doesn't seem to be anyone that knows of a validated tool at this time. So if no one else has questions, we can close out a little early. We do appreciate everyone for joining us today. I think we got pretty much everyone from our Learning Collaborative, so that's great. And please feel free to contact myself or Lisa with additional questions, or if you need resources, you know where to find us. So thank you very much.